Hello, everyone. Thank you for joining today's Web Interface Support webinar. This series of webinars is for accountable care organizations, ACOs, and groups that are reporting data for the quality performance category of the Quality Payment Program through the CMS Web Interface for the 2018 performance period. These webinars will highlight important information and updates about reporting quality data and provide ACOs and groups with the opportunity to ask CMS subject matter experts their questions. During today's webinar, we will also share links to various resources and other information that will appear as announcements on your screen. Please note that these calls will only focus on reporting data for the quality performance category. We will not cover reporting data for the other performance categories during these calls. Now, I will turn it over to Aruna Jasti from the Center for Medicare and Medicaid Innovation at CMS. Please go ahead.
Thank you, Stephanie. Good afternoon, everyone, and welcome to the CMS Web Interface Q&A session for the 2018 quality reporting for MIPS groups and ACOs. Next slide, please. This is our disclaimer slide. Please contact the Quality Payment Program if you have any questions. Next slide, please. The webinar materials from the last two sessions are now available on the QPP webinar library. You can access the links to the recordings, slides, and transcript for the February 27th webinar, and you can also access the slides for the March 6th webinar. Next slide, please. We have a few important reminders for you today. We are getting close to the end of the web interface submission period. The web interface will close promptly at 8 p.m. Eastern Daylight Time on Friday, March 22nd. And we would also like to remind you that the web interface will automatically accept your submission at the end of the submission period. Next slide, please. This slide provides information on the CMS approved reasons. Please be sure to submit your request by Friday, March 15th to allow time for CMS review. Requests sent after March 15th are unlikely to be processed prior to the close of submission. Next slide, please. And this slide includes steps you should follow to request a CMS approved reason. You are required to submit one request per patient per measure. Please include the patient rank, measure ID, detailed reason for the request, and do not include any personally identifiable information or protected health information in the request. Next slide, please. The next Web Interface Weekly Support Call is on March 20th. This session will be the last one before the Web Interface closes on March 22nd. Next slide, please. And now I'll turn this over to Sarah Grallett for the assignment and sampling overview.
Thanks, Aruna. You can go ahead to the next slide, please. Over the next few slides, I'll be reviewing the assignment and sampling process. As you know, the CMS Web Interface allows organizations to report on a predetermined set of beneficiaries. In order to determine that set, the following steps are taken. First, we assign beneficiaries to an organization. Then we determine the quality and denominator eligibility for those beneficiaries. And lastly, we select beneficiaries into each measure sample. Next slide, please. So the first step of that process is the assignment step. And this is the methodology used to determine which beneficiary is attributed to an organization. This is assessed based on where the beneficiary receives the plurality of their primary care services. One thing to remember is that if a beneficiary is assigned to an organization in 1 year, it may not be assigned to the same organization the next year. So for purposes of the CMS Web Interface, CMS used, for the Shared Savings Program, assigned beneficiaries from the third quarter assignment file. For the Next Generation ACO, aligned beneficiaries, we used the third quarter alignment file that was updated for exclusions. And for MIPS groups, we used assigned beneficiaries as of October 26, 2018. Next slide, please. And this slide just gives us some links to helpful documents that would walk you through the assignment methodologies for MIPS, NG-ACOs, and shared saving program ACOs. Next slide, please. So the next step is the sampling process. Assigned beneficiaries may be sampled into one or more of the CMS web interface measures. The first step of this process is to determine if assigned beneficiaries are deemed quality eligible, and this includes looking to be sure that the beneficiary had fee-for-service Medicare as their primary payer, they're not in hospice, they are still living in the U.S., and they are not deceased. It also looks to be sure that that beneficiary had at least 2 primary care visits within the ACO or group. The next step of the sampling process is to determine denominator eligibility. This includes looking for certain criteria to meet denominator eligibility within a measure, things like age, diagnosis as applicable, and also looking for required encounters as applicable for each measure. It's important to note that the encounters do not necessarily need to occur within the ACO or group at this step, but when we're looking for denominator eligibility, unless it's required by the specific measure. The last step of sampling is to select beneficiaries for each measure. As I mentioned earlier, as much as possible, we will try to sample beneficiaries into more than one measure. The organizations will receive a sample for each measure. So 13 samples for 13 measures. We'll have 616, except for PRES 13 will have 750 beneficiaries. Each organization is required to confirm and complete data entry on 248 beneficiaries or 100% of denominator eligible beneficiaries that you're able to confirm into the denominator. And next slide, please. Each beneficiary will have rank in the measure, so 1, 2, 3, and that's the beneficiary's rank. And then lastly, we have included here a link to the sampling methodology that includes a lot more information on the requirements for quality eligibility and denominator eligibility. And that completes this overview. I will turn it over now to Angie Stevenson, who will present on frequent measures questions. Thanks.
Hi, this is Angie Stevenson with the PIMS Measures team. We wanted to review a couple of questions we've been receiving frequently at the Quality Payment Program. Next slide, please. First question is on PREV 9 for the BMI follow-up measure. For the BMI follow-up, where a patient has a BMI over the normal parameters, and the chart indicates the physician discussed diet and exercise or diabetes or hypertension at that same visit, does this meet the measure specifications? Or does the follow-up note need to mention the BMI? It does not, so yes, this would meet. If the most recent BMI is abnormal and there's documentation that the diet and exercise was discussed with the patient at the encounter, then it meets the intent of follow-up, even if the notes don't mention the BMI. As long as the follow-up plan would impact the abnormal BMI as well as the other diagnosis mentioned, it is acceptable. The second question is for the IBD-2 measure. If a patient has a documented allergy to aspirin, how should I submit? The answer is you should answer no. If the patient did not have an active medication of aspirin or other antiplatelet during the measurement year, as the measure does not allow a medical reason denominator exception. There are other antiplatelet drugs besides aspirin that can be used to meet the measure. Thank you very much. I will turn it over to Lisa Marie Gomez.
Thanks, Angie. Next slide, please. So we're just going to briefly go over some resources for you. We know that we have about a week and a half left for completing reporting for the web interface, but here are some resources in the event that you do need extra materials to help you complete the reporting process. So as you know, a lot of our materials are on the QPP resource library, and here is the link. Also, you'll find other information relative to reporting that all relates to the web interface on the Quality Payment Program resource library. Next slide, please. Again, here are some other resources. As you know, we have published and produced videos that will help you as you continue to navigate and complete reporting for the web interface. So again, here are the links to the videos. Also, if you have any questions or need support, again, please visit the QPP website and you can find help and support there. Also, again, all of our materials for the web interface, so there's videos, materials, fact sheets, guidance, all of that, again, is on the QPP website. And we'll actually go on to the next slide. So on this slide, if you want to go back and review any discussion that occurred for the previous webinars, here are all the links to the webinars from previous webinars. Again, there's you can listen to them or read the transcripts, but they're available for you on the Quality Payment Program website. Next slide, please. If you have any questions or need further information in regards to the Medicare Shared Savings Program, here's the resources, the website, and also where to get further information. Also, if you have any questions with regard to Next Generation ACO model, here, please contact their service center, or you can email them or visit the website links here. And also stay tuned to all the materials that they do provide in their weekly newsletters that are provided to you all, because there is also useful information as we begin to conclude the web interface reporting period. All right, next slide, please. All right, if you have any questions, as you know, please contact the Quality Payment Program Service Center. You can send an email or call. If you have any questions with the Medicare Shared Savings Program, you can send an email, or the Next Generation ACO model, you can also send an email if you have any questions relating to anything relating to reporting or any questions relating to those programs. All right, next slide, please. All right, so before we get into the Q&A session, I just want to go over a couple of items. So you all send a lot of questions via the chat, and we do look at the questions, and we're not able to answer every single question, but we do look at sort of themes. And last week we saw that there was 2 areas where you have some questions. One pertains to group reporting, and the other relates to Prev 10 benchmarking. So we're going to briefly go over that before we go into the Q&A session. So I briefly wanted to discuss some of the questions that were asked last week, as I noted, relating to group reporting. Folks asked, how does group reporting relate to data completeness? So data completeness, when we think about data completeness, that relates to reporting quality measures outside of the web interface. So if you're reporting quality measures outside the web interface, such as using a QCDR, qualified registry, or EHR, data completeness relates to that when there's that 60% threshold. For the CMS interface, the web interface requires that all users or groups are required to report on all measures, and you're supposed to complete reporting for every single measure. As I mentioned last week, we discussed scoring for the different measures. So all the measures are scored, and if there is a benchmark, obviously those particular measures will be scored. If there's not a benchmark, those measures will not be scored as long as you complete the reporting requirements for that measure. If you do not complete reporting requirements for measures that do not have a benchmark, then you will be scored on that particular measure. And whatever you score on that will be included in the denominator. So again, if you have any measure that has 240 consecutively ranked beneficiaries or more, you're required to report on a minimum of 248 beneficiaries. If you have any measure that has a sample less than 248, you're required to report on all of those beneficiaries in that particular sample. So as I noted, I just want to go over how scoring works with regard to groups reporting via the web interface. Now in regard to PREV-10 and benchmarking. So although the rate for population 2 was not previously calculated in the CMS web interface, the data elements used to calculate it were captured. Previously submitted data on population 3 contained data elements that captured beneficiaries identified as tobacco users through screening, as well as which of those beneficiaries received cessation counseling. These data elements were used to simulate rates for population 2, and those rates were used to create benchmark for 2018. Initial analysis conducted on data entered into the CMS web interface for 2018 for the web interface reporting thus indicates that the established benchmarks for ACO 17/PREV-10 are acceptable, and the change in timing for tobacco intervention guidance does not impact the usability of the established benchmark. All right, so those are just the two items we wanted just to briefly go over. Now I'm going to turn it over to Michaela.
Thank you, Lisa Marie. So we are now going to start the Q&A portion of the webinar. You can ask questions via chat or via the phone. To ask a question via phone, please dial 1-866-452-7887. And if prompted, please provide the conference ID number, which is 429-6797, and be sure to press *1 to be added to the question queue. And if you do have any follow-up questions or clarification that you'd like to share in the chat, please type follow-up question at the beginning of your chat question so you can flag that for us. So our first question says the IBD measure specs state that the patient needs to have a diagnosis of ischemic vascular disease. The physicians in our practice use the terminology coronary artery disease. Is this acceptable for the diagnosis, or do the patients need to have IBD?
Hi, this is Olga from the PIMS team. So you would need medical record documentation to confirm acute myocardial infarction, coronary artery bypass graft, or percutaneous coronary interventions in the 12 months prior to the measurement period, or an active diagnosis of ischemic vascular disease during the measurement period. The IVD2 denominator coding can be used to assist with this. The coding provided is considered all-inclusive for the purposes of EHR mapping, but if there is medical record documentation that matches a description in the coding, such as coronary artery disease, then it'd be appropriate.
Thank you. This next question says, if the PHQ-2 is 0 for the depression screening and is scanned to the visit date, does it still require acknowledgement? And if so, what would that acknowledgement be?
This is Deb from the PIMS team. So if it is in the medical record on the date of that encounter and the score is 0, you can use that. The acknowledgement is really for the provider to have reviewed the screening that was done. However, we are aware that if that screening is part of the medical record, it is tied to an encounter with an eligible provider, and the assumption can be made that that eligible provider is aware of the screening being completed. And since a score of 0 can be assumed to be a negative for screening, a negative screening for depression, then again, that can be used. Thank you.
Thank you. This next question is on PREV-7, flu vaccine. If a patient had allergy testing and was diagnosed with an egg allergy in July of 2018, which is not in the flu season date range, can we use this as an exception?
So this is Deb again, and I would say no, you can't use that for an exception for this submission period, and the rationale for that is you're indicating that that is a new identification of an egg allergy, so it would not have been a reason that the patient did not receive the flu vaccine between October of 2017 and March of 2018. However, that documentation would be sufficient moving forward as a rationale for not providing the flu vaccine. Again, there could be circumstances where a flu vaccine would still be provided in those circumstances, but that denominator exception, once it is identified, can be used moving forward at this point in time. But I would say that each program year you would want to ensure that that allergy is still appropriate for not receiving a flu vaccine. Thank you.
Thank you. Our next question asks, are MIPS scores available in the CMS web interface for all measures or just those that are PFP? Where can we find the MIPS scores and or benchmarks for the 3 PFR measures in the CMS web interface? And they're asking about PREV 13, MH1, and CARE1.
So in regard to the web interface measures, so the measures that you see in the web interface only relate to what you're reporting for the web interface. But if for groups, you're also measured on the administrative claims data. So on the all-cause readmissions measure. So that data will not be available in the web interface in terms of that. So the only data that you will see in the web interface and the scores, or at least in terms of completed reporting, is what you see in the web interface. You won't see anything outside of when you completed reporting. David, do you want to add anything to this?
Yeah, unfortunately, I don't have the answer. I think what they're asking about is the 3 measures that are pay for reporting and are not part of the web interface score. I guess they're not seeing feedback on the rates for those. And I can't speak to the user interface and the way the feedback works for the web interface. We would have to take that back to the UI team.
Hi, David. I can try to speak to that. This is Aslam. So in the web interface, once you complete the minimum reporting requirements, that's the 248 beneficiaries, then you will see a score for that measure. However, you will not see a score for PREV 13, MH1, and CARE1. Once you meet the minimum reporting requirement for these 3 measures, you will see an NA instead of a score. But the other measures, once the minimum reporting requirement is met, then you will see a score in the web interface. Thank you.
Thank you. And Stephanie, do we have any phone questions at this time?
Our first question is from Jason Shropshire.
Hi, can you hear me?
Yes.
Yes, I have a clarifying question regarding the PREV 10 measure. So if we have a patient who was screened for tobacco and wasn't counseled, let's say July 10th, can we have someone call that patient, let's say August 10th, to provide counseling? Will that count for follow-up?
Hi, this is Angie from the PIMS team. Yes, the counseling can occur over the telephone, and as long as it has been during or after that most recent, the visit where the most recent tobacco use status was documented, then it would meet.
So as long as it's after that but before the end of the performance period, that counts. I just want to make sure.
Well, it would have to be after the most recent and before, right. And as long as there were no other documented tobacco use statuses subsequent to that, then it would meet. Yeah, yes, and during the measurement year. It should be actually tied to that encounter in some fashion, noted that it was due to that most recent tobacco screening.
But you're saying it does not have to occur on the same day, and it can occur weeks after as long as it's in reference to that tobacco screening.
According to the measure specifications, yes. It's during or after, and based on the most recent tobacco use screening result.
All right, thanks.
You're welcome.
All right, our next question asks, for PREV 13, if the LDLC lab value only states too high to count, How do you report this value?
Hi, this is Angie again. It is in the measure specifications that if the laboratory is unable to calculate an LDL-C value due to high triglycerides, then you would select no. Or if the test is labeled unreliable, you would select no as well. Thank you.
Thank you. Our next question is on PREV 12. If the provider documents depression in an encounter note, including before the measurement period, but does not code the condition, and it is prior to the encounter with the depression screening, is this a denominator exclusion?
This is Deb. First of all, you would want to ensure that if that diagnosis of depression is considered active still during the measurement period. So if there's something that occurred prior to the measurement period but you're not able to confirm it's active during the measurement period, then you would not use that as an exclusion. Additionally, the measure steward has confirmed that in order to claim the denominator exclusion, there needs to be an active diagnosis of depression or bipolar disorder prior to the encounter with the most recent depression screening, being the numerator event. If the diagnosis occurs during but not prior to the encounter with the most recent depression screening within the measurement period, then the patient would not be excluded. The denominator exclusion guidance is the same as in previous years, but for 2018, CMS did add the denominator exclusion timing on page 9 of the measure specification to align with the guidance provided in the 2018 corresponding ECQM. Thank you.
Thank you. And this next question is on the diabetes measure. If you are unsure as to the date of the A1C value, can you use the default date of December 31st, 2018?
Hi, this is Angie from PIMS. No. There needs to be medical record documentation of the date drawn and the HbA1c value to meet the intent of the measure. Thank you.
Thank you. And this next question is for Care 1, and they say, we have a CMS reported discharge date that is really a transfer to a skilled nursing facility. What do we do with this, as the MedRec has to be in an outpatient setting? And they note that this is the only CMS discharge date for this patient.
Hi, this is Katie. So if the patient did not have an outpatient visit, you would just answer no to the question asking if the patient was seen in the office within 30 days. In doing so, we'll remove this discharge from the performance calculations of the measure. Thank you.
Thank you. And Stephanie, we can take a phone question at this time.
Your next question is from Leela Nandon.
Hi, can you hear me?
Yes.
Hello? Okay, great. Thank you. I have a question. I was uploading some of our data today, and there were 3 members that I was not able to upload. I didn't necessarily get an error, but it basically stopped. It wouldn't accept because I didn't have 248 in consecutive. Patient number 180 had a, so this patient expired in 2017, and in another case, a patient no longer had Medicare fee-for-service, but in our EMR, the patient was on a Medicare Advantage plan in 2015. The error that I got was that when you say that a patient is not applicable for the sample, that you have to say, like, it has to be in this measurement year. In that case, do you want us to just use the default date of 12/31/2018, or what do you want us to do?
This is Deb. I am so sorry. Can you repeat that? I know you're asking about the date.
Yes. So when you upload the data, we have 3 patients that are not applicable for the sample, and they're not applicable because in one case we have a patient that expired in 2017. I mean, according to our EMR. And in 2 other cases, we have patients who did not, they're no longer on Medicare fee-for-service. In our EMR, we're showing that they're no longer Medicare fee-for-service, like I believe in 2015 or something, like not in 2018. In other words, the date that they changed their Medicare was in 2017, right? So my question is, I'm getting an error because those 3 patients, in order to not be applicable for the sample, the event, either expiration or change of Medicare, has to happen in 2018. In these 3 cases, it happened in 2017. So what do you want me to do in terms of, do you want me to put 12/31/2018 to get them? Yes. Is that what you want me to do?
Yeah, and this is something that we are going to look at because we do know that the language in there does talk about, if the date that it occurred during the measurement period is unknown, to enter that 12/31/2018. And we are seeing a couple of cases where patients may have entered hospice. It's documented in 2017 and not 2018.
Correct.
So yeah, at this point in time, the date should still be the same. Whether it is that you don't know the date and it occurred in 2018, or if you are finding documentation that they are not qualified for the sample based on previous years, that they're still relevant. Obviously, if you're deceased, it's still relevant. I know for hospice, sometimes a patient can be in hospice earlier and not in hospice in 2018, so you'd want to make sure that maybe being in hospice documented in 2016 is still considered relevant in 2018. But if you're finding that the situation hasn't changed at this point in time for the 2018 program year, go ahead and enter that 12/31/2018 date.
Thank you so much.
You're welcome. Thank you.
All right. Our next question is on Prev 12. If the PHQ-2 questions reference a different time frame, and they're saying in the last month versus in the last 2 weeks, is this considered acceptable for the screening tool?
And this is Deb. Yes, that would be acceptable. We certainly do, especially if you don't have documented the name of the screening tool that was used. We do like to see the PREV2 and the the PHQ2 and the PHQ9 questions to be as identical to what those tools use as possible, but we do recognize that sometimes there are slight variations in the language that's used, and that would still be acceptable to use. Thank you.
Thank you. And this next question is on Care 1. If the patient post-discharged was seen by a non-assigned physician, but by another physician in our ACO, can we still report positively?
Hi, this is Katie. So you can, I'm sorry, Michaela, I didn't mean to cut you off.
No worries. Go ahead.
It's appropriate to use this visit as long as it was considered outpatient, and you must ensure that you have the appropriate medical record documentation, which is outlined on page 5 of the specification. So as long as you have all the appropriate evidence for the outpatient visit, you can use it. Thank you.
Great. Thank you, Katie. And I think it looks like they have some kind of follow-up questions on this too, asking if this was done in a rehabilitation center, assisted living, or nursing home, can we still answer positively?
Sure, and that's where they would just need to confirm if the visit was considered outpatient or not. So if that particular visit was considered outpatient, they can use it. If it was not, then it should not be utilized for the measure.
Okay, thank you. And this next question is on the depression remission. If a patient has a diagnosis of MMD within the index date time frame, but then was diagnosed in 2018 with bipolar disorder, is the patient considered an exclusion?
So the patient would be considered an exclusion in this case as long as that diagnosis occurred prior to the end of the measure assessment period. So this is one of those cases where you can't just have a diagnosis that meets the denominator exclusion criteria that that is identified sometime prior to the end of the measurement year, it actually has to occur prior to the end of the measure assessment period. And that measure assessment period is determined by the index date and then looking forward 12 months plus or minus 30 days. So as long as that diagnosis occurs sometime within that 12 months plus or minus 30 days, then it would be appropriate for you to select the denominator exclusion. Thank you.
Thank you. And this next question's on PREV 7. Is the verbiage declines immunizations in the proper time period for the flu vaccination enough to select patient reasons exception for this measure?
And this is Deb again. Yes, that would be appropriate, much like if you found documentation of vaccines up to date during the flu season being measured, you can use that to identify that the flu vaccine was provided. Again, ensuring that this is documented during the flu season that is being measured by the measure, and that is October of 2017 to March 31st of 2018. And you also have that previous receipt time frame that starts in August of 2017. Thank you.
Thank you. And Stephanie, we can take a phone question at this time.
Your next question is from Melody Danko Halsenbach.
Hello. Can you hear me?
Yes.
Hi. I'm the director of an ACO. I have a question on, I believe it's PREV 10, the tobacco screening, bringing that back up. And I know at the beginning they read the disclaimer that they had enough information from previous audits to establish a benchmark. I think what we are questioning is the way that the measure is written and the fact that the counseling has to be after the most recent screening for the patient, and it doesn't count until that. Our issue with that is that providers were not informed of that that's what was going to count prior to the submission period. Like, we're just finding out about it. So it's not necessarily whether the benchmark is fair, it's whether the providers are informed of what the actual measure they're being measured on. Before, it was always a 24-month look back, that if the patient had tobacco screening, were they counseled for that screening? And with the second step of the measure being employed this year, it's creating a very big difference in the outcomes, and it may have been a specialist that saw the patient in that last visit, even though a primary care provider had already screened them and counseled them several times during the last 2 years.
So this is Deb from the PIMS Measures team. The one thing I will identify, and then there might be some other feedback that other folks on the call have that would be even more helpful, but I do know that that identified change in the measure specification would have been posted prior to the first of the year. So those measure specs would have been posted prior to January 1st of 2018, along with the release notes that give a general overview of things that have changed in the measures. Knowing that we need to get those specs out for people to be able to review for any changes. And I know in the past for the web interface, that was one of the things we tried to do based on feedback we received from the ACOs and the group practices. We used to not post those specifications until after submission closed so that there was no confusion between the measures being submitted for one particular year and then, of course, the posting of the next year's measures. And CMS did make that change to ensure that everyone had access to those specs prior to the measurement year. So just wanted to make sure that that is something that you're aware of. Like right now, I know that we're getting 2019 questions based on the fact that those 2019 specs are also posted. But again, I'm not sure if anybody else can provide some additional detail and information for you in regards to this question.
Yeah, and I just feel that the intent of the measure is not being met because providers, even though they've counseled, are being penalized for maybe one miss, when in the past 2 years they have definitely counseled these patients more than one time.
Yeah, again, I can only, that change to the spec was provided based on information from the measure developer PCPI, so I don't know if there's anything else that we can provide at this time. But if you have additional questions or if you feel like I'm not answering your question, you're more than welcome to either, again, ask one right here live, or we can certainly follow up if you'd like to open up a help desk ticket.
Yeah, I think we just want to be heard that when there's changes like this, the specs may go out, but there's interpretation issues. So when there's differences like that, it would be helpful if they were brought to the attention, within those documents that there, changes to these documents, please be alert or something, and then a way to provide feedback to measure developers, on these situations.
Okay.
But that's all I needed. Thank you.
All right. Thank you.
All right. Our next question is on DM2. If I can confirm DM from office visits early in the year, but the last visit in 2018, the physician states patient lost weight and is no longer diabetic, do I confirm or exclude the patient from the measure?
Hi, this is Angie from PIMS. The measure denominator criteria does say to determine if the patient has a documented history or an active diagnosis of diabetes during the measurement period or the year prior to the measurement period. So you would include them in the denominator for the measure. Thank you.
Thank you. And this next question is a follow-up from the slide deck on BMI. It was stated that a follow-up plan discussing diet and exercise is acceptable for the BMI measure, even if there is no BMI in the note or relation to an out-of-range BMI. Can you please confirm this is a pass?
This is Deb. I would say if you have a recommended follow-up with no calculated BMI, abnormal BMI, this would not be a pass. We can certainly go back and look at the slide deck and the response that was provided for that BMI question, but I think there might be a misinterpretation. You can have an abnormal BMI that does not have a recommended follow-up, and then you can look back up to 12 months from that BMI to see if you can find another abnormal BMI with a recommended follow-up that can be used. But you can't find an abnormal BMI without a recommended follow-up, look back 12 months and find a recommendation that might be relevant to an abnormal BMI, but no documentation of an abnormal BMI. That would not count as a recommended follow-up for that particular measure. If that's not enough detail or I'm not quite answering your question, please feel free to either ask the question live on the call or submit a QualityNet help desk ticket, and we will be able to give you an answer based on your scenario. Thank you.
Thank you. This next question says, there is a patient in the Care 1 sample that has two discharge dates listed, September 29th and September 30th. And they say that they can verify the September 30th discharge date as the patient was in the hospital from September 25th through the 30th. How should we answer the question about confirming the discharge date plus or minus 2 days, since both of these discharge dates are within that plus or minus 2-day window?
Hi, this is Katie. So in this scenario, we would encourage you to verify the discharge date that matches your record. So that date with the 30th. And then for the other one, if you're unable to confirm that discharge date, we would advise that you select no to the question if the patient was discharged from an inpatient facility plus or minus 2 days. So just confirm the one date that you're able to and do not confirm the second. Thank you.
Thank you. This next question asks, can we leave a patient incomplete? For example, if a patient is ranked 200 for PREV5 and in the oversample rank 616 for IVD2, can we just enter data for PREV5 and leave IVD2 blank?
Hi, this is Aslam. If a patient is ranked in multiple measures, you only need to complete those measures that the patient is ranked in the minimum reporting requirements. In this example, patient is ranked 200 in PREV 5. That's in the minimum reporting requirement, so PREV 5 questions will need to be answered. However, for IBD, patient is ranked as 616. That's outside of the minimum reporting requirement. The patient is in the oversample, and you do not need to complete the questions for IBD for this beneficiary. Thank you.
All right, Stephanie, we can take a question on the phone at this time.
Your next question is from Susan Bender. Susan, go ahead with your question.
Is that supposed to be Susan Gunter? That's close enough, I think.
Yes.
Okay. Yes, this is in follow-up to the statement that somebody had a question about DM2, that could they use 12/31/2018. There is actually a square box in the web interface on each patient's ranked page where you can enter data that has a question mark. And if it says, if date is unknown, enter 12/31/2018. The date must be within the performance year. Enter a date between 1/1 and 12/31/18. It's actually in the web interface on each page, on each patient's ranking information that can be entered.
Hi, this is Angie. Aslam can confirm, but I believe that is in the patient confirmation section. Where they're asking if the patient's qualified for sample, and if the patient became not eligible for the sample, like they were in hospice, were deceased, moved out of the country, then you would say no, and then that's where it allows you to enter a date between 1/1 and 12/31/18. Is that what you're seeing?
Okay. That is what I'm seeing. I just wanted to confirm that that doesn't just take, because it doesn't state that, so it could be confusing, and that could be why somebody asked that question.
Yes, and I looked in the DM specifications first very carefully, seeing if it said that, but it does say the date drawn is required. And
okay.
And then, because I remembered it being there too, but it's for patient confirmation in general. But thanks for
thank you.
Pointing that out.
Thank you so much.
Yeah, and this is Deb. I will say for that DM measure, the one thing that I think the specification also shows, because we definitely need a hemoglobin A1C value that happened during the measurement period, but there are times that the month and the year is known, but the date isn't known. And in those cases, I do believe that specification provides guidance on how to submit a full date if you don't know the actual day, but you have the appropriate year and the month.
Okay, that helps too. Thank you so much.
You're welcome.
All right, our next question's on the DM7 eye exam. Can we confirm that a dilated eye exam from an eye care professional in 2018, if there is no mention of diabetic retinopathy in the report? And they note that state law requires a retinal exam, fundus exam at every visit for a refraction/vision test.
Hi, this is Angie from PIMS. For a 2018 exam, it sounded like you have the report from the eye care professional with the date of the exam being in 2018. And if you can confirm that it included a retinal exam, it would meet the intent of the measure. You only need documentation that the exam was negative for retinopathy for exams performed in 2017. Thank you.
Thank you. This next question's on the CARE 1 measure. If the discharge date cannot be validated or verified, do we skip that patient, or can we assume the discharge happened if the patient had an outpatient visit a couple of weeks from the discharge date?
Hi, this is Katie. So no, you cannot make the assumption regarding the discharge just because there was an outpatient visit. You must have medical record documentation and be able to confirm that discharge. So in this case, if that's not available, you would answer no to the question, was the patient discharged from an inpatient facility on the date listed plus or minus 2 calendar days? Thank you.
Thank you. And our next question's follow-up.
Michaela,
yes.
This is Lisa Marie. I just want to insert really quickly. I just want to let folks know that we are seeing your comments with regard to Prev 10 and the benchmark, and so we will continue to monitor Prev 10 once submission closes. So again, thank you all for your comments. I just want to let you know we will monitor that measure. Thank you.
Thank you, Lisa Marie. So it looks like we do have time for one more question, and this is a follow-up to an earlier question on the PHQ score of 0 being okay to use as considering a depression screen negative, even if the provider did not specifically mention their impression in their notes for Prev 12. So this person's asking, does that also apply for a PHQ 9 score of 0? Or does that apply for PHQ-2 score of 0 as well?
So this is Deb. There are 2 cases where you can make an assumption of whether or not the depression screening is positive or negative. The first time that you can make that assumption is if you have a score of 0. We typically say if you have a score of 0 for your PHQ-2 or your PHQ-9, but it is possible a score of 0 would be an assumption as a negative depression screen for other standardized screening tools. So you would want to look at those. If they're scored numerically and you're scoring a 0, we can assume that a 0 means negative for depression. The other time you can make an assumption is if you have a screening and then you have a recommended follow-up. If you don't have documentation of positive for depression screen, but you have a recommended follow-up, then we can also assume that the depression screen was positive. So it would count for both that PHQ-2 and the PHQ-9. Again, this is also assuming that screening is part of the medical record, and it is something that the provider is taking responsibility for. I also want to take this opportunity because I've seen a couple of Prev 10 questions and some concerns about the documentation in that measure specification, and I'd like to point people to page 13 of that posted measure specification so that you have something to kind of go back to and look at and see if this answers your question. Within the numerator guidance note, there is a third bullet that says that the screening for tobacco use and cessation intervention do not have to occur on the same encounter, but they must both occur during the 24-month look-back period, and the cessation intervention must occur after the most recent tobacco user status is documented. So this is the information that we've been providing in our responses and why we are stating that cessation intervention has to occur after the most recent tobacco user status is documented. And again, that is on page 13 of the Prev 10 measure specification. Thank you.
Thank you. And that is all the time we have for today. If we can go to the next slide, please. And if we weren't able to answer your question, please do feel free to send a note to those email addresses that we shared earlier. And here they are again for help with the Quality Payment Program, the Medicare Shared Savings Program, and Next Generation. And we also sent those out as an announcement that you should have seen pop up on your screen. And we encourage you to join us again next week for our next and our final webinar in this series on March 20th. Thank you.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.